I'd like to acknowledge my co-authors, one of our fellows who just finished, Christina Goldstein, and some of our research analysts included in the paper. We all know that the cost of spine surgery continues to increase, and in many countries it's at par with chronic diseases such as diabetes, cancer, and non-spinal arthritis. And as we all know, that the burden of disease and treatment requirements continue to increase, and as such, our current methods for spine care, spine advocacy have to change, and decision-making around healthcare delivery is continuing to shift and will continue to do so in the years to come. And most countries are certainly looking more and more on switching from fee-for-service type healthcare delivery to more value-based evidence and service delivery based on comparative effectiveness. So if we were to continue to advocate for new technologies such as showcased in this type of forum, we really need to show comparative effectiveness both on a clinical aspect and then also on an economic perspective, and that was the purpose and objective of our systematic review, looking at fusion specifically for degenerative lumbar spinal conditions. This was a standardized systematic review following approaches recommended by the Cochrane Low Back group, of which I'm a member. And we looked at two types of studies. One, clinical studies that were comparing open versus MIS T-lifts or PLIFs, and any health economic studies that were available that compared the two procedures. Our hypothesis being is if we can show clinical equivalence or non-inferiority, then the potential benefits of perioperative, reduced morbidity, et cetera, would theoretically be in favor of advocating for MIS surgery for fusion compared to open procedures. We performed a standard systematic review through different archives and noted up there our mesh terms. The study was limited for publication bias in that we only restricted it to English language studies. The literature search, we also added independent searches from PubMed as well as hand searches through the references of included papers in a standard fashion. Our inclusion criteria are important to note in that to give you a sense of what we were studying, and we only use comparative cohorts from within the same center. As there is regional and geographic variation for length of stay, surgical techniques, we wanted comparative groups within the same hospital and within the same country or institution to be compared. There had to be at least 10 patients in each comparative group, and we compared the traditional midline approach to a paramedian muscle splitting approach for T-lift or PLIF, adult patients with lumbar degenerative pathology, and the studies had to report at least one validated clinical outcome and also outcomes around adverse events or economic analysis or all of the above. We went through a standardized data extraction portion with two independent reviewers throughout the study, looking at study design, patient demographics, et cetera, in a standardized way for systematic review. We graded the level of evidence using the grade protocol, and if there were any discrepancies between reviewers, consensus-based agreements were used, and a third author was utilized for any discrepancies we could not do. Between group comparisons used parametric, non-parametric studies and statistical analyses. We looked at mean differences for pooled data with regards to continuous variables and risk ratio for non-continuous data. And we assessed for heterogeneity between the study groups using standardized statistical methods. With our searches, we started off with about 4,300 papers. And as you can see here, the exclusion criteria applied. We ended up with 26 papers that allowed us comparative assessment between groups. One was a randomized trial, 11 prospective studies and 14 retrospective cohort studies. And if we look at the pooled number of patients in these studies, it was 856 MIS versus 800 open. The quality of evidence, however, was very poor overall, with low to very low quality, very low being dominant, and even the randomized trial, due to small sample size and patient heterogeneity, was graded at a very low level, a low level. When we looked at was there reasonable comparison between the groups, there was fairly good homogeneity around age, gender, number of levels. The diagnosis as a whole were fairly equal. However, most studies, and pretty much all of them, did not present data separately so that we could sub-analyze between degenerative disc disease, spondylolisthesis. So there was some diagnostic heterogeneity which would pool the data, which would give significant bias with regards to confounders. When we did a meta-analysis of more process-type data, surgical time was actually not statistically different between the cohorts. The estimated blood loss was in favor of MIS, which we all already know, so that wasn't a surprise. But if you can see here in the forest plots, consistently all studies essentially showed reduced blood loss. When we looked at length of stay, again, consistently all studies showed a mean of 2 days, almost 3 days difference between groups with regards to length of stay. Surgical risk, intraoperative adverse events were relatively equal between the groups. However, there seemed to be reduced medical complications, pneumonias, bladder infections, etc., were statistically significantly less risk in the MIS cohort. When we looked at clinical outcome, and the median time of these studies, fortunately, was longer term, so we had a median of 2-year follow-up within the groups, minimum of 1 year. And essentially, there was a statistically significant difference in ODI, but clinically, all of us would agree that that's really equivalent change. A 3-point change is not clinically relevant. When we looked at economic studies, without getting into the details, most of them were just comparing cost and not necessarily comparing outcome, except one study, but on average, from the hospital perspective only, so very limited perspective, there was overall consistently less cost associated with the MIS procedures, driven by the complication, driven by the less length of stay, that ranged anywhere from 10 to 24%. So in summary, the evidence from 26 poor, but at least comparative studies, really the best evidence that's out there, did show improved perioperative outcomes, which I think we all know, and this group is obviously very much in favor of that. But we did show equivalent patient reported outcomes at a median of 2 years, and consistently showed some decrease in hospital costs, which as a whole, if we have clinical equivalence but some perioperative benefit and reduced costs, it would favor towards MIS. However, the biases of these studies really limit any strong conclusion, and at the very least, I think based on the current literature, we can state that MIS posterior lumbar fusion is not inferior with regards to patient-reported outcomes, but is superior with regards to the acute perioperative outcomes demonstrated in this study. The health economic analyses, there was one cost utility, and there's another study out now by Matt McGirt, which does take a perspective of societal costs, so productivity loss, return to work, and they're showing a benefit in that regard. So I do think that more data obviously needs to come, but from a hospital perspective, there's an advantage around cost savings. Going forward, obviously, we need better studies, but a randomized trial, when you have such potentially small differences in clinical outcome, is not likely to occur, and we need more data from prospective registries or multi-centered prospective studies will help us try to determine this. And I think one of the bigger benefits that is not well studied will be economic data around return to work, return to activity, and productivity or societal cost. Thank you.